So we're going to talk first about the impact of early trauma and recommended interventions. And this is important for us to know because, you know, we all work with these kids who went through trauma, and we all work with their parents. We all know how hard it is to sometimes explain or try to make them understand why their kids are having the behaviors or emotions, or you know, how they're presenting, without understanding what happened to this child. So in the next slide, you'll see the objectives. So we're going to introduce the concept of adverse childhood experiences, and I'm sure many of you are very familiar with this concept. And then we're going to explain the impact of trauma on brain development, and we're going to introduce available treatments. So child maltreatment is obviously one of the biggest public health problems. So some people advocate it's the single biggest public health problem right now, with nearly 3 million children annually suffering from trauma or some sort of abuse. It's predominantly perpetrated by a parent, family member, or any other adult caregiver. So it, you know, home, which is supposed to be the safest place, is usually not for these kids. The most prevalent one is psychological maltreatment. Emotional abuse happens in 36% of identified cases, emotional neglect in 52% of identified cases, and many times it's combined. So most of you are probably familiar with this survey. So this is the Adverse Childhood Experience Questionnaire, that you can get online for free. And that's where you can get an ACE score. And so there was this big study that showed that when you have a score of 4, at least 4 or more than 4, your chances of developing a series of psychopathology and even medical problems or psychosocial problems in lives increase substantially. So it's a good questionnaire to use with all your kids that you work with, in order to have a baseline of what they've been through so far. So the next slide talks about the ACEs. So we know the effects of trauma are cumulative. So the most adverse childhood experiences you've been exposed to, or with multiple exposures, you carry a greater symptom burden. And there's something called population attributable risk, where is how much of a disease or a behavior could be eliminated if we eliminate something else. So if we took away the ACEs, we could decrease current depression by 54%, which is higher than removing heredity. We could decrease suicide attempts by 58%. We could decrease alcohol abuse by 65%, drug abuse by 50%, IV drug abuse by 78%, sexual assault by 62%, domestic violence by 52%, and promiscuity by 48%. So this is how it could be if there were no ACEs. That's how much it would end up being eliminated. And so basically childhood maltreatment in childhood increases the risks for virtually every DSM diagnosis. And the question is how, you know, how can abuse lead to this psychopathology? And from a neurodevelopmental perspective, we know that childhood trauma, so abuse, leads to alteration in systems in the brain which mediate the stress response. And neglect leads to a dysfunction in neural systems because there's not enough stimulation, and it's not timed, patterned, or repetitive enough as for some brain areas to develop well. So in order to understand that, let's just talk a little bit about our brain. Obviously, it's designed to sense, process, store, perceive, and act on information from the external and internal world in order to basically keep us alive and functioning. So there's so many neural systems in there that we don't even know very well, and that are there's processes that happen that lead to modulation, regulation, compensation, increasing or decreasing activity to control the body's physiology. And each of these physiological systems in our body has a rhythm of activity, and it's going to regulate key functions. And this, so anything that alters the brain obviously is going to show a very big impact in many areas: behavior, emotions, bodily functions, regulation. So going to the next slide, we can see that brain development doesn't end when we are born. So it starts happening very rapid in utero in the first years of life. And then disruptions in molecular processes that take place in this period results in abnormal organization and function. And the impact would depend on the nature, timing, and frequency of maltreatment. So it's not the same if there was one single episode of abuse at age 9 than a kid who was exposed to substances in utero, then went to was removed from the family because of abuse, placed in foster care, removed, placed with multiple disruptions in attachment. So that's something that we need to explore with every kid. And of course, brain development is kind of genetically determined, so predetermined, but how that potential that we come with is expressed is a function of timing, nature, and pattern of experience. So whatever happens has an effect that will lead to the full development of our genetic potential or not. So this is just what happens in brain development. So you have neurogenesis, where that happens mostly in utero, where the nervous system is forming, just like any other organs. And alterations, of course, can have a very devastating impact on the fetal brain growth and result in profound psychopathology later in life. After there's the neurons and the central nervous system is formed, there's a series of events that happen, like migration of neurons, usually in utero, but also in the perinatal period and continues throughout childhood. So this is not something that can only be affected in utero, it can be affected later on. There's differentiation with neurons develop into serotoninergic neurons or dopaminergic neurons or noradrenergic neurons, or what kind of other neurons they're going to become. Then you have the formation of synapses, where the neurons start connecting between them. And again, during the first 8 months of life, there is an 8-fold increase in synaptic density. So, it just continues to happen as we move on with life. And then other things that happen in the next slide, we have apoptosis, which is the programmed brain cell death. And that's something that we all go through, but depending on what areas are stimulated, those are the ones that won't have apoptosis. So this is programmed, but then depending on what's used and what's not used, those are the parts that are going to survive or not. And you have synaptic sculpting, so where the synapses starts to develop into other connections. And it's kind of a use it or lose it thing. So again, if there's no activity of the neurotransmitters in those synapses, then those synapses get lost. And so those connections won't persist. And myelination is just like a sheet of myelin that forms around the neuron, that surrounds the neuron and makes the connection better or faster, the transmission of the information. And that continues throughout childhood, and in adolescence is very important. So brain development doesn't stop when you're born, basically, and anything that happens during these vital periods is going to have an impact, or has the potential to have an impact. So in the next slide, we can talk about, basically, there's chemical processes that drive development in utero that are genetically determined, and then there's environmental processes that will be mediated by the senses, mostly initially, that play a major role, and even more so by adolescence. So the interactions with caregivers are critical to brain development, and what happens in those first years of life is critical to brain development. We need this attachment. We need the proximity-seeking behavior towards a trusted other to increase the felt sense of safety. So we have all these kids who have so many disrupted attachments, and this doesn't happen or is not appropriate. And then we have arousal regulation that also will be critically kind of developed in this period of time. And so it basically begins with co-regulation, where the primary attachment figure is going to help them co-regulate. And it's also not only the attachment figure, but also sensory motor activity and executive functioning will help later on with the regulation piece. So this development is usually sequential, so it happens from bottom up, so from more primitive functions to more complex functions. So brainstem, diencephalon, limbic system, cortex, and the final organization of more complex areas like the cortex will be influenced by what happens before with the lower neurons. So each brain area also has a sensitive and critical period for development. So if you don't, if the brainstem has to be intact at birth in order for the baby to survive, because there's vital functions that happen there, like breathing, regulation of heart rate, temperature. So this is needed at birth. And then the development of brainstem allows for the development of the further higher functions. So in the next slide, we can see a little graph that talks about it in a more kind of explaining what functions will be developing from each layer. So the brainstem, you can see more vital functions. Then we move up to sleep regulation, appetite, arousal, motor regulation, emotional reactivity, sexual behavior, attachment, a sense of affiliation, and then thought processes or more executive functioning. So this is obviously all of these can get affected if we don't have an appropriate brain development. So again, it's activity dependent, so it's a use dependent fashion, and the molecular cues that guide development are dependent on the experiences of the developing child. So if the kid lacks the experiences that are needed in that specific developmental stage, those are not going to develop well, and those are not going to allow for other features to develop well. So the sensory experience of the child, we know, is very important at this age, and the exposure to adverse experiences disrupts the neurodevelopment, leading to a chaotic, developmentally delayed, and dysfunctional organization. And then, so the triggers for disruption. So you can have the lack of sensory experience during those sensitive periods. You can have the atypical or abnormal patterns of necessary cues due to extreme of experience. So in abuse, you have an extreme exposure to stress response. The children are usually more vulnerable to trauma and neglect than adolescents and adults. So we see more consequences because, of course, the brain is just developing, and you have more developmental stages to miss at that time. And positive experience later in life may not be sufficient to overcome the disorganization, depending on the degree. Of course, there's neuroplasticity, so you can have some positive outcomes there, but it's something that we need to be aware and explain to parents. So the next slide, how can child maltreatment then impact both neglect and trauma-related abnormalities in neurodevelopment would act as a primary mediator, so directly altering neural systems and creating psychopathology. Then the other way is trauma and neglect can play an exacerbating or expressing role for neuropsychiatric symptoms in individuals who were already genetically vulnerable. So they might lead to a earlier expression of the symptoms that they were going to express, or they wouldn't have expressed in a more contained and appropriate environment. And then the symptoms and problems that are caused by maltreatment can be disruptive for other developmental opportunities. So a kid who doesn't develop co-regulation will have later on problems with regulating with peers, will have social difficulties, will have learning difficulties, and this will lead to subsequent abnormalities in their development. So again, when we talk about neglect, we're talking about some areas are not exposed enough to what they were supposed to be exposed. And then we have the stress response system, which is hyperactivated in a kid who's abused. And so this stress response is so severe, unpredictable, prolonged or chronic, that it leads to an overactivation or fatigue of the compensatory mechanisms and in an inability to restore the state to the baseline, to the what we call homeostasis. So basically, in the next slide, we see trauma makes the physiological system reorganize the basal pattern. So we have like a new baseline. It's not back to being calm. Is, you know, instead of kids getting on their alert state and then going to terror and coming back to a calm state, they have their new baseline is not calm. It's more like hyper alert or hyper vigilant, or, you know, in fear, constant fear. So, you know, there's a cost to survive in the traumatic experience. And this is often matched by an extreme and persistent internal activation of the stress response system. So let's, in a new context and without any true external threat, they can feel like they are threatened. And that's where you see all these kids who have so many trust issues or have a very extreme reaction to a minor trigger or a trigger that nobody can identify at the time. So it's kind of an abnormal persistence of a once adaptive response that becomes maladaptive. So here are some of the human survival responses. So you have the freeze and scan when you see something that causes danger, that activates this arousal system. And then, you know, kids can either have the fight or flight response where that leads to hyperarousal, or adults for that matter. Or you can see the fright submit response that leads to dissociation. So they don't feel like they can defend themselves, and it just dissociates in order to be able to tolerate the situation. And that's when we can see some persistence of this dissociation as the kids grow up with the triggers that many times are not recognized. So again, it becomes a maladaptive trait. And then, you know, how long the systems are activated during the actual traumatic event will have a key role on how the psychopathology develops. So what is important from this slide is that the predictable and moderate exposure to stress leads to resilience, but unpredictable and severe exposure to stress leads to vulnerability. So this is exactly what happens with these kids. So in kids, the classic PTSD picture is not common, except if we have a discrete single traumatic event. But the typical presentation is more complex. So you can see impulsivity, negative self-image, social avoidance, dissociation, sleep difficulties, affect dysregulation, which can be like an excessive dysphoria or numbness, concentration problems, distractibility, aggression. So it leads to many misdiagnoses in kids with complex trauma, such as ADHD, MDD, ODD, conduct disorder, separation anxiety, phobias, and also you can see comorbidities. So sometimes it's not a misdiagnosis, it's just you have both conditions or many conditions going on. And then you commonly see school failure and regressed or delayed development. So we have kids who, you know, maybe in their motor functions, they're very able to walk and do everything that's expected, but emotionally, socially, and, you know, they're not ready or they're not at their age level. And we're asking them to act at a certain age that they're not ready for. So in younger children, we can see more of the separation anxiety, sometimes sexualized behaviors when they're being exposed to sexual abuse, behavioral problems, ADHD-like symptoms, affect dysregulation, dissociation, somatization. In adolescents, we see a lot of the conduct problems, substance abuse, school problems, risky behavior, self-harm, suicidal ideation, depression, dissociation, and somatic symptoms again. The females tend to exhibit more internalizing symptoms and males more externalizing symptoms. So you see all these boys who are very aggressive and, you know, aggression is one of the main presentations of kids with trauma. And females tend to dissociate more than males as well. So that's where, because of the lack of usually presentation of PTSD in children. There's this mention of developmental trauma disorder that's probably going to come up in one of the DSMs in the future, where we're trying to be more aware of developmental difference between kids who have been to trauma and adults who have been to trauma, and what develops later on. So you have the traumatic victimization and primary attachment disruption, and then characteristically you have dysregulation, and that's a very key word, dysregulation. So affective and physiological dysregulation, attentional and behavioral dysregulation, and self and relational dysregulation. So in the next slide, you can see kind of what the proposed criteria for this disorder will look like. And this is still in study, and the people at the JRI Institute, JRI are doing a lot of work into this, and I believe they're pioneers. But basically, you see a lot of the symptoms that we see in these kids. So dysregulation in presence of cues, and cues that many times they're not even something that we can perceive or the kids can recognize. Yeah, that was my trigger. So affective dysregulation, somatic dysregulation, behavioral dysregulation. You have cognitive dysregulation, relational dysregulation, self-hate, blame, things like that. So this is kind of what it's going to probably look like at some point, but it's just to exemplify how we can see the symptoms in kids as compared to adults. So that's, I think I was pointed enough that dysregulation is key, but basically the ACEs study showed us that there's a lot of long-term consequences that can happen from having 4 or more ACEs, or it increases the chances of even various medical conditions, not only psychopathology and psychosocial problems. So moving on, we're going to talk a little bit about treatment. Obviously, prevention is the best treatment, but usually when the kids come to us, that's kind of too late. So obviously, we want to make sure that there's in a trauma treatment, there's a safety in the environment. There's a skills building in emotional and behavioral regulation. So we want to help them co-regulate and regulate themselves later on. Growing positive attachment relationships. So this lack of attachment figure that didn't happen in there when it was supposed to happen, we need to create some sort of attachment with them. And it doesn't have to be us, but we have to find that attachment somewhere. Meaning making, so trying to explain what happened and, decrease the self-blame and guilt about, negative perception of themselves, and developing a positive sense of self. Obviously, since the development happens bottom up, we try to take a bottom up approach as well, being cognizant that we want to develop the basis first before going to the more cognitive or executive functioning part. And of course, the intervention needs to be tailored to the developmental stage of the patient. And we, of course, need to be aware of current safety concerns. So if there's any ongoing threat, we need to take the appropriate measures for that. So of course, we need to consider timing of trauma. So when did it happen? How many times did it happen? Single versus repeated trauma, because that's going to lead the treatment. If it's a single event, it might be fewer symptoms and less treatment resistant. For chronic or pervasive trauma, there's more complex symptoms, as we talked about, and it might be needed, a more lengthy treatment might be needed in order to return, and a need to return for additional courses as they reach different developmental stages. So we also need to recognize, intervene for cognitive and developmental issues. So, it's a multidisciplinary approach, and that's why we want to bring this ECHO as a multidisciplinary place as well. So comorbid symptoms need to be addressed. The nature and severity of the symptoms will define the treatment approach rather than the diagnosis. So what do we need to target first? Sometimes we have so many symptoms that we don't know where to start. And then the characteristic of the child and the family. So what is the genetic predisposition for this child? What is the gender? What previous stress exposure exists? attenuating factors such as a good supportive caregiver and the age of the child. So younger kids do better in dyadic approaches, and older children, individual teenagers do very well with groups as well. And then these are psychotherapeutic interventions that are recommended for trauma. So you have SMART, and Elizabeth Warner, Dr. Warner recently came to give us a SMART training, and we're trying to get this set up in the community in different places. So, and she's probably going to talk to us a little bit more about it during this series of echoes. Trauma-focused CBT, we have attachment, self-regulation, and competency model, or ARC, which is something that you're going to be hearing a lot from, and I think that's kind of the model that we're going to approach the most in this echo, because I'll talk a little bit more about it in a few seconds, but we kind of feel like this is a very evidence-based model, that it's not only a protocol that you follow in your office, but you can adapt it to different settings. And as such, we're going to bring, as part of a recent grant, we're going to bring some training in the community for ARC. So we want to kind of continue that model in our ECHO as well. Then you have child-parent psychotherapy, you have preschooler parent psychotherapy, EMDR, play therapy, school-based or group therapies. And then you have some ancillary therapies, so sensory integration, OT, yoga, neurofeedback, animal-assisted therapy, acupuncture, recreational therapy, art therapy, music therapy, movement therapy. So all these therapies can be incorporated into the treatment plan as well. So ARC, basically attachment, self-regulation competency, works with children and caregivers in order to help them recognize the dangers, differentiate current and past dangers, build skills in managing the responses, and kind of lay the foundation for development of competencies. So we're working on attachment, we're working on self-regulation, we're working on competency, and basically supporting the caregivers along this process in providing a safe context. And again, it's applicable in different settings. It's not only in an office with a manual. It's can be applied in group homes, can be applied in residential facilities, in any milieu. You can teach the persons who are with the kids how to apply this model. It's evidence-based and it's flexible. So rather than a structured protocol, you identify goals for intervention, you identify skills involved in reaching these goals and examples and ways to get there, but you make it more individualized for every kid as what you choose to use for depending on what you see. So it consists of 9 building blocks and a 10th target of intervention. And so the next slide shows the blocks, and basically the lower one would be the attachment piece. So we want to work on caregiver affect management, attunement, a consistent response, and routine and rituals. Then you have the self-regulation layer, which is affect identification, affect modulation, and affect expression. And then you have the competency layer, which works on executive functions and self-development and identity. And then you have a final task that's a developmental task that incorporates all of the ones below. Is kind of a final goal of the therapy. But what we want to do with this echo is kind of go through all of this in from a different standpoint, from a psychiatry, therapy, occupational therapy, what kind of interventions we can kind of exemplify to make this more practical for the community, so that we can all discuss cases and see how we are applying these blocks and how, what kind of results we see with the kids and in the different milieus where you work. So then there's, for psychopharmacological treatments, there's really nothing that's curative, obviously, and generally the symptom reduction that's obtained with psychotherapy is much larger than what's associated with pharmacology. So you have antidepressants, not particularly beneficial in kids with PTSD or complex trauma. You use if you see comorbidity with depression or anxiety, but you're not using it to treat the PTSD. Then you have antiadrenergic agents, which might be what shows more promise. So guanfacine can decrease scores for re-experiencing avoidant and hyperarousal symptoms. Clonidine can attenuate reenactment symptoms in children. Prazosin may be effective for, nightmares. And propranolol might be effective also to decrease some of the symptoms. So you have that hyperadrenergic activation from the exposure to stress. And I think these are the agents that are kind of modulating a little bit of that hyperarousal and increasing autonomic response or instability. Then you have antipsychotics, which are widely used, but basically there's some evidence, but they're reserved in adults for comorbid psychosis or overwhelming agitation and aggression. In kids with, who also have autism with irritability, aggression might be a good choice. But sometimes we kind of tend to overprescribe a little bit. Mood stabilizers have some evidence, but really in kids, not so much. And other medications, really, we don't typically use benzodiazepines. They're especially in pediatric populations. And then naltrexone has shown some efficacy in adults, but not really. I haven't read anything in kids for that. So these are mostly conclusions. So child maltreatment, we know, is common, associated with negative outcomes. We see complex trauma with persistent, early, and repetitive trauma, which typically presents with dysregulation in different domains in functioning. Obviously, there's a direct impact of trauma in the developing brain, which influences the clinical manifestations, and then also an indirect impact of these brain development features and other features of development. And prevention is key. And obviously, psychotherapeutic interventions and ancillary therapies show more promising results in symptom reduction as compared to